are aware that this is a problem. And then the patient takes some time to accept it. And then we decide what kind of help they are open to and what kind of help we can give them. मोटा मोटा ये symptoms हो गया है. I would quickly like to wrap up with just the numbers. इंडिया में 20% आबादी में at any given point of time डिप्रेशन की बीमारी रहती है. इनमें से 10% लोगों में घबराहट और डिप्रेशन दोनों रहता है. घबराहट एक अलग बीमारी है, मन का विकार जिसे बोलते हैं या उदासी की बीमारी अलग चीज है, बट ओवरलैप करते हैं सिम्टम्स, स्पेशली बिकॉज मोस्ट पीपल गो फॉर ईयर्स विदाउट डायग्नोसिस. सो वी हैव टू डिफरेंशिएट एंड ट्रीट इट अकॉर्डिंगली. नाउ आउट ऑफ दैट 20% ओनली 30% कम टू अ क्लिनिक. तो 70% आपकी छुपी हुई आबादी में बीमारी है. आउट ऑफ दैट 30% प्रॉपर ट्रीटमेंट खाली 10% लोगों को मिलता है. तो 20% लोगों को प्रॉपर ट्रीटमेंट भी पूरा नहीं मिलता है. तो उनको लगता है कि इसको ट्रीट करके होगा क्या. आप बात ही तो करोगे, आप दवाई दोगे, and then दवाइयों से related there are a lot of myths. We'll get into it again later.
Ma'am, there are one question really. Individual is asking, is medication the only solution for depression, or can yoga be more helpful?
Look, I always prescribe yoga and meditation also. It cannot be fully curative. It also depends on the stage, age, and the patient profile. हम डिप्रेशन को कैटेगराइज करते हैं. थिंग्स आर वेरी साइंटिफिक नाउ. ये खाली बात करने वाली चीज नहीं है कि मैंने हवा में बोल दिया उदास हो तो डिप्रेशन हो गया है. माइल्ड डिप्रेशन में आपकी एक्सरसाइज, लाइफस्टाइल मॉडिफिकेशंस, डाइट को मैनेज करना, थेरेपी, टॉक थेरेपी करना, दैट विल हेल्प. इट कैन बी क्योरेटिव, यू कैन गेट आउट ऑफ इट. मॉडरेट टू सिवियर डिप्रेशन, जब आपकी केमिकल चेंजेस इतने हो गए हैं कि ये सारी चीजें नहीं हेल्प करती हैं, देन यू नीड मेडिकेशन और अदर ट्रीटमेंट मोडालिटीज. अब तो बिना दवाइयों के भी ट्रीटमेंट ऑप्शंस हैं हमारे पास, सो वी कैन डू दैट. There are nasal sprays, there are IV injections. The US has a lot of these options. India में अभी थोड़ा धीरे आ रहा है. Magnetic stimulation. So no, ये myth है कि बिना दवाइयों के हम lifestyle से ही ठीक कर लेंगे. आप delay करोगे. Get a proper diagnosis. Let your doctor decide what you need. Make a team with a therapist and a psychologist and a social worker. Then proceed.
Okay.
So, Dr. Kisley, I wanted to ask you something. You know, we use this word depressed ho gayi hu main very loosely.
Yes.
It's like, you know, it's almost like a slang.
It has become slang. It is overused, and I personally totally disagree with it. आप उदास हो गए हो, आप डिप्रेस नहीं हुए हो, right? But I can't entirely disagree with the slang and the popular usage of it, because at least it is becoming part of the conversation.
Yeah, yes.
एक वो conversation का दरवाजा खुलता है तो हम उस पर नाराज नहीं हो सकते, but I would appreciate if people clarify the differences and then take it back to their communities and families and talk about it.
Right. You also mentioned that, depression is different in genders.
Right.
Would you like to,
Yes.
we recently did a post on how depression can also affect men, not just women. So can you just talk a little bit about both and what is the difference, or what is it, how does it manifest in the genders?
Right. Now, most people don't like to talk about it क्योंकि वो feminism या gender bias वाला angle आ जाता है. But there are differences in genders because historically and culturally we have differences in our genders. Women and men can do everything that you want to do, but it will manifest differently. Historically, women have been more home-based, care-based, emotional work ज़्यादा करती हैं, तो उसमें manifestation अलग आता है. Men are more, outside the house, you have an image to project, you have work to do, so उनमें different आता है. Biologically also changes are slightly different. Not to offend anyone, but depression का एक लक्षण होता है sex drive गिरना. Now in women, it does not manifest as much as men, because the performance here starts dropping. And that is where it starts impacting the self-esteem and relationship and marriage. So the premature ejaculation एक entity होती है, erectile dysfunction एक entity होती है, and up to 60% of them are secondary to depression. So those can be treated, but men don't like to talk about it, and they don't let their partners talk about it. That is one stark difference. Second is emotional expression. Women are used to being more emotionally expressive in our culture. आदमियों को बचपन से सिखाया जाता है रोना नहीं है, बात नहीं करनी है, etc. So in women it will manifest as sadness more. दोस्तों से बात करना हो जाता, लेकिन घर का काम करती रहती हैं. In men, irritability comes out. Also we kind of give a free rein to men. आप घर में अगर आवाज उठा रहे हो, गुस्सा कर रहे हो, it's kind of accepted. So nobody notices it as a huge change unless it starts impacting outside relationships. आप बॉस पे गुस्सा नहीं करोगे, वाइफ पे करोगे, बच्चों पे करोगे. So irritability is the second stark difference. Crying spells. Women will cry. Men will feel like crying, they will not cry. And the last and most, from a clinical point of view, major difference is suicide attempts. Women में होगा, maybe complete नहीं होगा, it will be a cry for help. Men will keep thinking about it, never talk about it. When they attempt it, it will be more serious. So the damage might be more if they survive. If not, we have lost somebody. मोटा मोटा ये अंतर है. Women will be picked up easier. Men will be picked up much later because they hide it much better. Right? And they don't let other people talk about it. They have fewer friends in an emotional capacity. आपके घर में अगर लेडी है कोई, तो कम से कम आपको ये पता चल जाएगा कम काम कर रही है, धीरे काम कर रही हैं, रो रही हैं, इमोशनल सीन आ रहा है, टीवी पे बहुत भावुक हो गई हैं, रोना स्टार्ट कर देते हैं. The man will get up and walk away. So it takes time to pick up these things.
Okay. Yeah. Navya, would you like to come in and ask something?
Sure. So, ma'am, like as you said, there's a gender differences. So there would be some symptoms which are more observant and more evident in the young adult as compared to older age group. So what are the signs and symptoms that we can observe in young adult, which is quite different in older adults?
Right. So one thing that is common but manifests differently across the ages is isolation. एक loneliness करके लोग report करते हैं कि हमें अकेलापन लगने लगा है. That will manifest differently in the sense कि younger age group, 50 and below, will start withdrawing from their friends, their work circles. वो खुद बात कम करना शुरू कर देते हैं. That is isolation. Older adults, senior citizens, will be हम अकेलापन महसूस करते हैं और वो उसको normalize कर देते हैं क्योंकि अकेले रहते हैं, family बाहर रहती है. Anyway, we are not used to senior citizens having their own, what you call your own life or your own social circle. So it is more easily missed. That is how it manifests differently. वो बाहर जाना पसंद करते हैं लेकिन अकेलापन consistently महसूस करते हैं. जब चले जाते हैं तो उनको अच्छा लगता है. Whereas here, when they're isolating, if somebody forces you to come out, initially you will be very irritated. You might have fun. वापस आके आप फिर उदासी feel करोगे. That is how it's different.
Okay.
Also, younger age group and older age group, again, I'm taking a rough division of 50, but senior citizens हम 60 to 65 मानते हैं. The biological changes in senior citizens will slow you down mentally. Whereas in the younger age group, that is a later manifestation. आप physically अपना काम करते रहोगे because you have to start with more energy. Whereas in senior citizens, that is to begin with, it's a little low. तो वो अपना work करते रहेंगे, घर पे थोड़ा आलसी हो जाएंगे. Here you will see 24/7 slowness of movements, slowness of memory, slowness of interaction. बाहर से बच्चों का फोन आएगा कि आजकल बात नहीं करते हैं. Those are differences that we need to be more careful of as family members and community members. Okay.
Thank you, ma'am. So when we identify there are symptoms that we have been observing, which could be, diagnosed as depression. So what should be our first step when we know that we are experiencing the symptoms?
Personally, if somebody is feeling it themselves and they want to do something, contact a doctor, either a psychologist or a psychiatrist, whoever's available, whoever you're more comfortable with. पहले जाके आप diagnosis clear करवाइए. फिर आपका treatment plan बनेगा and then continue with that. Because these are not illnesses that have developed overnight. Very rarely acute onset होता है, हफ्ता 10 दिन में होता है. But most of them are taking time to build up. There are multiple stressors, biological changes happening. So the treatment will also take that much time. उतना अपने आप को time दीजिए. ज़्यादातर लोग वो नहीं करते हैं. They want overnight solutions. We are addicted to dopamine. We are addicted to overnight solutions, but this is something that takes time. So that is your first step. And the second step is sticking with whatever plan is made.
So there's one question, ma'am, like our audience is asking. It is also very common that we don't like to, take medication. So what that needs to be done?
Honestly, I would, for most of these patients, first I try to understand why you don't want to take these medications. बुखार होता है आप दवाई लेते हो, दर्द होता है आप दवाई लेते हो, बीमारी होती है आप दवाई लेते हो, तो दिमाग की बीमारी के लिए क्यों नहीं लेते हो? There are a lot of fears. Addiction हो जाएगा, छोड़ नहीं पाएंगे, लाइफ लॉन्ग चलेगी. साइड इफेक्ट इसके ज्यादा होते हैं एज अपोज टू एंटीबायोटिक से भी एसिडिटी होती है, एंटीडिप्रेसेंट से भी होती है, बट यू पुट मोर एम्फोसिस ऑन दिस देन दिस. So the first step is, why do you not want to take medication? Second is addressing those concerns. Third is deciding बिना दवाई के किसी का काम चल सकता है कि नहीं. Like I said, mild depression, we can try other things. Moderate to severe, you need treatment. Treatment does not always have to be medication. Like I said, there are newer modalities now. वो patient profile को देख के हम fit करते हैं.
So मैम बहुत सारे clients के concerns रहते हैं कि हमने medication start कर दिया, there's a lot of side effects. So should we just stop the medication abruptly? So what would you suggest to those patients or clients?
I would suggest go and hit your doctor's head. Do not leave them. अगर इतना साइड इफेक्ट हो रहा है कि आप टॉलरेट नहीं कर पा रहे हो तो मेरी गलती है वो. एज अ डॉक्टर दैट इज माय रिस्पॉन्सिबिलिटी टू मेक श्योर दैट द साइड इफेक्ट्स आर बीइंग बैलेंस्ड आउट. आपको एसिडिटी हो रहा है तो मैं एंटासिड दूंगी. आपको चक्कर आ रहा है, बीपी कम हो रहा है तो मैं आपको बोलूंगी पानी और पियो, नमक और पियो, और आई विल चेंज द मेडिकेशन. आज के तारीख में हमारे पास खाली 1 या 2 दवाइयां नहीं है. दिस इज नो लॉन्गर द 1970s मेडिसिन, राइट? So we have like 6 types of antidepressants. We have newer antidepressants with no side effects. तो ऑप्शंस हैं, आपको और आपके डॉक्टर को मिलके सोल्यूशन ढूंढना पड़ेगा. Sometimes the side effects are balanced out by other medications. And most 70 to 80% of my patients, within the first 4 to 5 days, you get used to those medications. And those side effects tell me that the medicines are acting, right? So it's not घबराइए मत, परेशान तो ये कंटिन्यू करिए.
Right, that's true. There's another question. How would I know that the doctor is following a proper process, or is the CBT a good way to treat these issues?
CBT is absolutely a good way to treat these issues. Most practitioners, most psychiatrists will prescribe CBT along with medications. Now, unless it's severe depression, where I say कि 4 हफ्ते के लिए दवाई खाओ, फिर CBT start करो, because otherwise you're stuck in a loop with your therapist. Therapist भी frustrate हो रहा है, आप भी परेशान हो रहे हो, and both of you lose hope in the process. कि ये तो काम ही नहीं करता है, which is not true. It will work when your mind is ready to receive those ideas and follow those guidelines. CBT in mild depression alone will work. It is a good therapeutic process. उसमें दवाई की जरूरत नहीं पड़ेगी आपको. Moderate to severe, I would recommend hand in hand it goes.
Okay, right. Ma'am, what are the common issues that we can observe as a symptoms along with depression?
Okay, depression itself can present in any psychiatric illness. इसीलिए लोग साइकेट्री को बहुत वेग मानते हैं, क्योंकि हर कोई चीज में हर कोई सिम्टम दिख जाता है तो आप पता कैसे करते हो. बट इट्स वेरी साइंटिफिक. देयर आर गाइडलाइंस. इन डिप्रेशन इटसेल्फ, मैंने बोला घबराहट, मोस्ट कॉमन इज घबराहट से शुरू हुआ है तो ये उदासी कैसे है? हम तो उदास होते ही नहीं है, हम तो बड़े खुश रहते हैं, लेकिन हमें घबराहट होती रहती है. इट कैन बी सेकेंडरी टू इट बिकॉज द केमिकल्स आर द सेम. लाइक आई सेड इन द बिगिनिंग, केमिकल्स आर द सेम, पाथवेज अलग अलग हैं, इसलिए ओवरलैप होता है सिम्टम्स का. डिप्रेशन में समटाइम्स देयर इज ओवरथिंकिंग व्हिच इज मिस्टेकन फॉर मेनिया, जहां पे बहुत ज्यादा ओवर एक्टिविटी हो रही है ब्रेन की. बट दैट्स माय जॉब टू डिफरेंशिएट, ये डिप्रेशन से आ रहा है या किसी और चीज से आ रहा है. ऑब्सेसिव थॉट्स, लोग बहुत कंफ्यूज रहते हैं कि मुझे एक ही ख्याल बार बार आता रहता है, एक ही चिंता बार बार आती रहती है, तो ये एसओडी क्यों नहीं है, ये डिप्रेशन क्यों है. दैट इज वेयर आई नीड टू डिफरेंशिएट. इमोशनल चेंजेस पहले आए हैं या थॉट चेंजेस पहले आए हैं. योर माइंड इज डूइंग 2-3 थिंग्स टुगेदर. थिंकिंग ऑल्सो, मेकिंग अ जजमेंट ऑल्सो, ट्राइंग टू एक्ट ऑन इट ऑल्सो, एंड फीलिंग थिंग्स. अब आपके थॉट्स पे एक्शन डिपेंड कर रहा है या एक्शन की वजह से इमोशन आ रहा है. इट्स माय जॉब टू डिफरेंशिएट, राइट? So these are 2 most common overlapping symptoms is anxiety and OC thoughts. Less common, or actually very, very common symptom of depression, नींद में problem आना. And right, sleep. Sometimes you have early onset insomnia, जहां नींद पहले गड़बड़ होती है, उसकी वजह से डिप्रेशन होता है. कि आप उदास हो जाते हो, नींद कब आएगी, नींद कब आएगी, नींद कब आएगी सोचते रहते हैं, ओवर थिंकिंग होती है, आपको लगता है नींद ठीक हो जाएगी, सब कुछ ठीक हो जाएगा. But it's actually a symptom of depression. So these are the most commonly overlapping things.
So ma'am, as you said, like sleep and depression, go hand in hand.
Yeah.
So can sleep and depression cause hallucination, or is it, how can we differentiate?
Lack of sleep, the sensory deprivation, lack of sleep causes hallucinations. उसमें सुलाना ही एक उपाय है. आप या मैं भी 4 दिन तक लगातार अगर जगे रहे तो हमें भी चीजें सुनाई देने लगेंगी, दिखाई देने लगेंगी.
Right.
Treatment will be treating the root cause of it. Severe depression में भी hallucinations हो सकते हैं. There is an entity called severe depression with psychosis. Treatment is still antidepressants. Initially antipsychotic देते हैं. बाद में ट्रीटमेंट एक्चुअली डिप्रेशन होता है.
Okay, right. So, ma'am, like,
Hmm.
there's one
We have a
question.
question. Yeah,
Yes.
Navya, you take that question. Yeah.
Right. There's one question, ma'am. Like, some people don't want to take medication because depression has caused them to not want to take care of themselves.
Hmm.
And there's another question that my mom has dementia and it's getting worse in 2022, but some of her symptoms make me feel it started due to depression. How do I help her?
Get a proper diagnosis. अगर डिमेंशिया ऑनसेट होता है, नाउ डिमेंशिया में आपके एक एक करके केमिकल्स का लेवल गिर रहा है, न्यूरॉन्स आपके मर रहे हैं, मेमोरी पाथवेज अफेक्ट हो रहे हैं. सूनर और लेटर दोस केमिकल्स विल फॉल इन द इमोशनल सर्किट्स आल्सो. तो डिप्रेशन एक सेकेंडरी फीचर होता है डिमेंशिया का. ट्रीटमेंट हम दोनों का करते हैं. क्रॉनिक डिप्रेशन में जो आप भूलने का बात कर रहे हो उसको हम डिमेंशिया नहीं बोलते हैं, सूडो डिमेंशिया बोलते हैं. मतलब एक्चुअली भूलने वाली बीमारी या अल्जाइमर्स या पार्किंसंस नहीं है. डिप्रेशन की वजह से आपका मेमोरी रिकॉल स्लो हो गया है, आपको लगता है कि आपका कॉग्निशन स्लो हो गया, दैट इज सूडो डिमेंशिया. Treatment is different in both of these, which is why you need an accurate diagnosis between a neurologist and a psychiatrist. And that is how you help these patients. For step 1, accurate diagnosis. Step 2, treatment for every underlying cause. Dementia is irreversible, we know that. It's sad, it's slowly losing somebody. Depression is eminently treatable. Secondary depression is also eminently treatable. आप बोलोगे, लेकिन कम से कम emotional stability maintain रहेगी.
Okay. She has mentioned that her mother has mirrored self-misidentification and talks to herself, hallucination, and she cries a lot. So you would suggest, as you suggested, for a detailed evaluation would be the better way
That
to
is
go
more
ahead.
indicative of dementia, to be very honest. But yes, a detailed evaluation would help to start with. Depression में ऐसा बहुत uncommon होता है.
Ma'am, there's another question. Can depression be transient or permanent? Can there be episodes of it after a long gap, like a relapse?
Yes, yes, they can. We have different entities. Depressive disorder एक umbrella diagnosis है, उसके नीचे आपका major depressive disorder आता है जो कि chronic 2, 4, 5 साल तक चलता है. एक recurrent depressive disorder होता है जो episodes में आता है. 6 महीने का एपिसोड, 8 महीने का एपिसोड, इट कैन बी ईयरली, इट कैन इवन कम बैक आफ्टर 2 years और 5 years. उसमें फिर हम डिटेल फैमिली हिस्ट्री लेते हैं, आपके परिवार में क्या ये बीमारी थी. ज्यादातर लोगों के केस में ऐसा होता है, लेकिन हमें पता नहीं होता है. लाइक आई सेड, हमें पता ही नहीं था वो बीमारी है. वो थोड़े झक्की थे, वो थोड़ा अलग थे, बात नहीं सुनते थे या उदास रहते थे, अकेले रहने का उनको शौक था, राइट. So recurrent depressive disorder can happen at any time. Now relapse we call it if within 2 years the episode has come back after treatment. अगर आपकी दवाइयां डिसकंटिन्यू हो गई थी या आपने दवाइयां पूरा कोर्स नहीं किया या उसको लेते लेते आपके सिम्टम्स वापस आ गए, दैट इज अ रिलैप्स. Everything else is a recurrence or a recurrent depressive disorder.
Okay, right. There's one more participant who has asked, depression symptoms are so non-specific and treatment is a long-term process. Do we have any laboratory test for confirmation before putting the person on a medication?
Not okay. That's a two-part question. I don't think symptoms are non-specific. Once you have experience, like I've been practicing for 10 years, or as a patient you have experience, I have patients who've been suffering for 20 years. वो आपको specifically सारे symptoms बताते हैं. There is nothing non-specific about it. Maybe initially, like you were saying, Navya, when the overlap of symptoms is there, तब हमको non-specific लगता है. But there are very clear-cut signs and symptoms. हमारे पास एक चार्ट होता है जिसको हम टिक ऑफ करते हैं कि ये more than 4 symptoms out of this list of 7. Then we make that diagnosis. So slightly different, maybe opinion from an expert and a lay person. And lab test is a very good question. I get it very commonly. Unfortunately, आज की तारीख में ऐसा कोई lab test नहीं है. There are clinical tests. We have, again, lab tests in terms of research. स्पाइनल फ्लूइड में सेरोटोनिन का लेवल मेजर करना, सुसाइड स्टडीज में हम करते हैं. लेकिन अब आप खुद इमेजिन करो, अगर मेरे पास 20 पेशेंट आ रहे हैं दिन के, मैं बोलूंगी मैं रीढ़ की हड्डी में आपको सुई डाल के निकालूंगी, वो इट्स एक्सपेंसिव, इट्स पेनफुल, उसके साइड इफेक्ट्स हो सकते हैं. आई डोंट वांट टू टेक दैट रिस्क. यू डोंट वांट टू टेक दैट रिस्क व्हेन आई कैन मेक एन एक्यूरेट डायग्नोसिस बेस्ड ऑन अ 45-minute इंटरव्यू, राइट. सो द एंड आरबीसीज में एक केमिकल का लेवल गिर जाता है, वो भी रिसर्च लैब के लेवल पे होता है, वेरी एक्सपेंसिव टेस्ट. So there are some biological markers, they have not become mainstream. आज की तारीख में ऐसा कोई टेस्ट नहीं कराते हैं जिसके बेसिस पे हम ट्रीटमेंट स्टार्ट कर रहे हैं.
Okay.
What about imbalance, there's, I think the question is around hormonal imbalance, and if that can be a
If that
indicator.
is where the depression or depressive symptoms are coming from, yes. So when you come to me for these symptoms, I will always do a thyroid function test. Hypothyroidism entity में depression होता है. उसमें हम initially antidepressant और thyroid hormone replacement देते हैं. बाद में आपकी antidepressant छूट जाती है. PCOS. Now, one of the lists you'd sent me earlier, people are getting more aware. Brain gut axis. Ovarian and brain का axis. Those hormones are overlapping. Those chemicals are overlapping. उनका टेस्ट होता है, but it's not a diagnostic test. किसी को PCOS है तो मैं ये नहीं बोलूंगी कि आपको डिप्रेशन नहीं हो सकता या इसकी वजह से डिप्रेशन आया. It goes hand in hand. So we do test for those hormones. We do give those replacements, but we still have to treat for the chemical that is in the brain. आपका हार्मोन दिमाग में नहीं घूम रहा है, आपका हार्मोन बॉडी में घूम रहा है.
There's a question related to this, ma'am. Like, can depression cause thyroid fluctuation or eczema?
Eczema.
Yes, skin issue.
Okay. The skin issue, chronic skin. Okay, dermatology is a very good question. Chronic dermatological issues, chronic aesthetic या cosmetic issues can cause depression. ऐसा नहीं है कि डिप्रेशन की वजह से आपकी स्किन ड्राई हो रही है, आप सेल्फ केयर में निग्लेक्ट कर रहे हो, मॉइस्चराइज नहीं कर रहे हो, तब आपको स्किन प्रॉब्लम होगा. Depression itself does not cause it. It's because of the symptoms secondary to that. TSH is a very good question. Again, depression में TSH थोड़ा गिरता है, but it does not cause hypothyroidism. Hypothyroidism में depression आता है.
Okay. And ma'am, once we start with the medication, how can we monitor, the changes that has been, improving our course of illness for a period of time?
Right. So one is of course symptomatically जो patient आपको report कर रहा है वो खुद better feel कर रहे हैं या worse feel कर रहे हैं, side effect ज़्यादा महसूस कर रहे हैं या emotional improvement ज़्यादा महसूस कर रहे हैं. Caregivers and family members start seeing changes in behavior. चिड़चिड़े कम हो गए हैं, साथ में आके बैठते हैं, खाना खाते हैं, बाहर जाने का मन होता है, नहा लेते हैं, कपड़े बदल लेते हैं. And for me as a clinician, there are rating scales. Like I said, it's all very scientific. हम हवा में बात नहीं कर रहे हैं. For as much as it may sound like we are, हमारे पास क्लियर डायग्नोस्टिक गाइडलाइन, एक डायग्नोस्टिक स्क्रीनिंग टेस्ट होता है, एक रेटिंग स्केल होता है. उसमें माइल्ड, मॉडरेट, सिवियर हम हर विजिट पे मार्क करते हैं. एवरी 2 weeks we mark that. So if we see improvement in that over 4 to 6 weeks, we know your medication is working. Otherwise 6 हफ्ते के बाद, 2 महीने के बाद हम दवाई बदल के देखते हैं.
Okay, right. So screening is one of the way that would help to, see the improvement or for the diagnosis of an illness. Ma'am, there's another question. Can you elaborate on home care management of depression or maybe a self-care management to manage the depressive symptoms?
I think there's a related question to this, Kisle, that we get a lot of calls from people that, they have somebody in the family who has depression, but is refusing to seek help. And so I think that they're probably related, but if you can shed
Yes.
some light on this or advise, that will be really helpful for a lot of family members in helping their loved ones.
You're right. These are kind of related, and I would like to split it into different parts. Self-management या self-care management of depression. एक बार तो आप किसी डॉक्टर या साइकोथेरेपिस्ट या साइकोलॉजिस्ट, क्लिनिकल साइकोलॉजिस्ट से मिलिए, ताकि आपको पता चले वो किस सीवियरिटी पे है. Again and again, I'm saying the same thing, and I want everyone to take this home to their communities. Mild depression में आप ये सब कर सकते हो. Therapy करिए, खुद manage कर सकते हो. The usual things that we keep talking about, but nobody does. Get up on time, fix a routine. बच्चे के टाइम टेबल की तरह अपना टाइम टेबल बनाइए, खाने पीने पे ध्यान दीजिए, सोइए. Sleep is very, very important. Exercise करिए. 20 से 30 मिनट की exercise will change your outlook because it starts increasing the activity वाला hormones and chemicals in our body. Things like that you can do. Anything beyond that, you need help. अगर आप होम केयर सोच रहे हैं कि घर में रख के मैं इसके साथ लगी रहूंगी 3-4 महीने, आप बिहेवियर में थोड़े चेंजेस देखेंगे, but the minute you stop that, the patient will sink back. So don't delay that process of getting them proper, appropriate help. Second, and this is a very common, कि घर वालों को लगता है प्रॉब्लम है, पेशेंट खुद नहीं मानता है. There is something called insight, how aware we are of what is happening with ourselves and how much are we ready to accept that it's happening with ourselves. Now, this is a very cultural Asian phenomena, I would say. लोग ज्यादातर बोलते हैं कि तुम्हें उदासी का कोई कारण नहीं है तो उदास क्यों हो, right? And if you don't see those changes, you don't even accept it. And ourselves, हमने internalize इतना stigma कर रखा है ना कि ये तो दिमाग की कमजोरी है, मैं कैसे दिखा दूं, मैं इतना कमजोर कैसे हूं कि मुझे किसी बाहर की जरूरत पड़ रही है। आप ऐसा कभी नहीं सोचते अगर आपको फ्रैक्चर होता और आपको फिजियोथेरेपी की जरूरत पड़ती कि मैं कमजोर हूं, नहीं, हड्डी टूटी है, मदद चाहिए तो करना है, ट्रीटमेंट करना है। बट वी डोंट थिंक दैट वे अबाउट आवर ब्रेन. So home care management, please be very, very careful. Outside of mild depression or mild anxiety, where these lifestyle management and therapeutic techniques work, beyond a point, don't take matters into your own hand, right? And if somebody does not want help, just wrapping up a little long answer, आप उनकी मदद अपने लेवल पे एक, आर्मी में बड़ी सिस्टम होता है, दोस्त होता है who constantly checks in with you. So you can give them all the information. आप प्रिंट आउट निकालो, डिप्रेशन के लक्षण हर जगह गूगल पे करते ही 4 लिस्ट आ जाती हैं. These are the symptoms we are noticing in you. Do you see it in yourself? And leave it. Let them think about it. आप उनको रिसोर्सेज दीजिए, हेल्पलाइन नंबर्स होते हैं, डॉक्टर्स के नंबर्स होते हैं. You leave that. Now this is an equal relationship. As a parent, as a partner, as an elder, as a boss, you are well within your rights to take that person to a doctor. हम भी अकेले पेशेंट को नहीं देखना चाहते हैं. We need somebody who will give us history and corroborate the information we are getting. Sometimes patients are so depressed वो बात भी नहीं कर पाते हैं. So you can misdiagnose in that case. We need somebody to give us that information. तो आप जबरदस्ती ले जाना पड़, ले जाइए, क्या होगा, गुस्सा रहेगा ना इंसान 2-3 महीने तक, but you'll get them the help they need. They will not reach a point where suicide is an option or where the self neglect has become so bad कि बाकी diseases लग गई हैं.
Ma'am, if a family member is not understanding that I am going through depression or I have any mental health illness, what should be my step? How should I go ahead?
First and foremost, be a little selfish. It's about you, your life and your health. अगर कोई सामने वाला नहीं समझ रहा है तो इसका मतलब ये नहीं है कि आप उनकी बात सुन के अपना ख्याल रखना बंद कर देंगे. Continue with your medication, continue with your therapy. Bring that person to therapy. Make that person talk to your doctor and your therapist so they can explain to them कि क्या changes आ रहे हैं. Actually बीमारी है, right? Sometimes that helps. If beyond that they are still resistant to the idea, drop it, work on yourself, get back on track, and then be the community educator, outreach person. फिर आप उस पे focus करो.
Okay, right. So, working on ourselves is really important.
Yes.
We should not neglect our symptoms.
Until you help yourself, बाकियों को कैसे कर सकते हो ना?
Right. Yes, ma'am. If a caregiver is experiencing the burden, taking care of their care recipients who has been diagnosed with depression, can they also have depression on a long run due to the caregiver burden?
Absolutely. Now, this is where people feel it's a very, non-specific diagnosis. Long-term stress और depression का बहुत गहन रिश्ता है. Immediate, एक के बाद आपके losses हो रहे हैं फैमिली में, या कोई फाइनेंशियल स्ट्रेसर भी आ गया है, वर्क स्ट्रेस भी आ गया है, पर्सनल रिलेशनशिप में स्ट्रेस भी आ गया है. Constant stress can push you in a state of depression because it's reducing the hormones and the chemicals that are responsible for happiness or activation. Right? जैसे जैसे वो डोपामिन गिरता रहता है या कॉर्टिसोल एक स्ट्रेस हार्मोन होता है वो बढ़ता रहता है या कॉन्स्टेंटली एलिवेटेड रहता है तो आपके फिजिकल एंड मेंटल चेंजेस होंगे. नाउ फॉर caregiver burden, as Ms. Archana was saying, Samvedna has a very good outreach program for caregiver support. Now this is a rare thing that not everybody thinks of or provides, and it's very important क्योंकि थकान is a natural human thing to feel. जहां chronic illness से आप डील कर रहे हो, and it doesn't have to be mental illness, even physical illnesses. स्ट्रोक का पेशेंट होता है, डिमेंशिया के पेशेंट्स होते हैं, there are motor neuron diseases where a patient is bedridden or multiple sclerosis. Caregiver burden is a lot and we don't always think of them. So chronic stress में तो आप हो ही, constant fear of losing your loved one maybe and not even being prepared for it. So that is where caregiver outreach programs or caregiver
Hello. Hello.
Hello. I think this
Yeah. We lost Dr. Pisley for a second. Can you hear me, Navya?
Yes, ma'am. I can hear you.
I am there. Just
Okay.
some network issue.
Yeah. Hello.
Hello, doctor. Hello, ma'am. Hello, Dr. Kisle.
I think we have lost her. She'll just come back. So
Yes. As she was mentioning, ma'am, I would like to continue.
Yeah.
Like she was informing us about the caregiver burden. Yes, the stress to play a major role in the caregiving burden. A lot of individuals whose patient has been diagnosed with depression, dementia, or any other chronic illness do experience stress, and it leads to depression, anxiety, and other comorbid issues. So caregiver enablement or knowing the disease or working on ourselves being a caregiver really helps us to manage these symptoms. Dr. Kisley has joined. I'll hand over to Dr. Kisley.
Yeah. Just,
I agree with Navya. Everything you said is how you manage caregiver stress. बीच बीच में आप अपना evaluation कराते रहिए अपने डॉक्टर के साथ, just in case it hasn't reached a level where you need to be on medications. So just a small anecdote. Recently, I've had a patient, 52-year-old wife and 54-year-old husband. The wife had a stroke 3 months back. And आज की तारीख में the whole family is struggling. उनकी बेटी की शादी fixed है next month. So the mother is not able to run around and do those works. She's trying her best to get better. But because of this, एक post-stroke depression नाम की entity होती है. Plus, because you are aware of your physical deficits, you are depressed and you are being put on medication. I suggested to the husband कि सर आप भी ले लो थोड़ा सा low dose में, because emotional lability बहुत ज्यादा है. मूड स्विंग्स बहुत ज्यादा है. एक दिन आप बहुत चीयरफुल हो कि सब ठीक हो जाएगा, दूसरे दिन आप बहुत सैड हो, कुछ नहीं हो रहा है, 4 कदम पीछे जा रहे हैं हम तो. So in those cases, you need to be in touch with the caregiver, as me as the clinician, to be in touch with him and encourage him to take some help. So for now, our plan is he will go to the psychologist to learn resilience and coping skills for himself. Abhi wo dawai ke mood mein nahi hai. Hopefully it won't reach that stage, but I've given him a window of 2 months to see if the psychologist is helping him. And if that doesn't happen, then he's agreed to take medication. So it's just a small example, but you know how these things progress.
Right. So, ma'am, like as we were talking about the caregiver stress and the depression that the caregiver could also experience, is there any genetic relationship between, from one generation to another? If my father has depression, could I be susceptible to depression in the long run, in the near future?
Absolutely. It's like any other chronic or lifestyle illness. So again, I can give you stats as a clinician. मैं थोड़े numbers देती हूँ. दोनों पेरेंट्स को है तो आपको 40% चांसेस होंगे. एक पेरेंट को है तो 20% चांसेस होंगे. ग्रैंड पेरेंट्स में था, पेरेंट्स में भी था, so then it's a 50-50, right? One child will have it, one child will not have it. So yes, genetic predisposition है. हम उन सारी चीजों को कंसिडर करके डायग्नोसिस बनाते हैं और ट्रीटमेंट रेकमेंड करते हैं. Now this is actually a very good question because this is the exception that proves the rule. अगर आपके दादा को डिप्रेशन था, आपके फादर को डिप्रेशन था, and a male patient has come to me with depression and I have seen him at a stage where it is mild depression, I would still like to put him on medication and then send him for therapy to learn the skills to prevent a relapse in the future or not be face stresses better so that you don't get into moderate or severe depression. And that is where the genetics helps. Same goes for diabetes, हर आपके फादर को तो जरूरी नहीं है आपको होगा, but you are predisposed. So I'm going to be more careful with your diet and exercise and weight levels. Right?
Right. Yes. So what could be the preventive measures that I can take not to have depression since it's genetic in nature? What would you suggest, ma'am? Like what?
Everything I just said. First of start, awareness is the first thing. So it's very good if you know there is a genetic predisposition. List out the things that stress you out. Learn how to cope with stress better. Unfortunately, हमारे स्कूलों में ये नहीं सिखाया जाता है. ठीक है? To be very honest, nobody teaches you how to face stress. They will tell you, ये boards का stress है, ये exam का stress है, ये आएगा, ये आएगा, ये आएगा. But how do you deal with it? You don't know. So distraction techniques, grounding techniques, breathing exercises. घबराहट बहुत ज़्यादा हो रही है तो उससे कैसे handle करना है? For these patients, it's actually this subset of patients where you know there's a genetic predisposition. It's even more important to stick with your routines. Focus on your sleep, focus on your diet, focus on things that require more attention, less attention, make a chart, be in touch with a therapist. Honestly, I feel everyone should go to therapy in India, but that's a different ball game. But जहाँ पे आपको predisposition है, आप अपनी टीम पहले से चुन के रखो. Doctor से मिलिए, therapist से मिलिए, see who you're comfortable with and chart out these things with them, right? And give yourself breaks in life, generally, like a 6-monthly holiday or a vacation. Just to relieve stress so that you do not build up to such a point that you will get depressed.
Right. Ma'am, how should someone, deal when there's a self-harming thoughts and depression or a suicidal thoughts?
Okay, such patients need medication to stop such ideation. Suicidal ideas जहां आ गया है, it is clear cut, हमें और कुछ पूछने की जरूरत भी नहीं पड़ती है. Suicidal ideas automatically means it's severe depression. So get adequate help, get treatment. Medication will stop those suicidal ideas and acting out on it chances decrease हो जाएंगे. दूसरा, आप therapy start करो. There CBT literally teaches you आपके जो negative thoughts आ रहे हैं उनको कैसे रोकना है या convert करना है into something positive, right?
Right.
Now in a brain that's stressed out, anxiety वाले दिमाग में या depression वाले दिमाग में हम एक बहुत hyper stress situation में रहते हैं. You reach, अरे एक्सीडेंट हो जाएगा, उसके आगे आपका दिमाग जाता ही नहीं है, आपका दिमाग वहां अटका हुआ है, इसलिए आप परेशान रहते हो. Now you and me or anybody else, you'll be like, अच्छा ठीक है एक्सीडेंट हो जाएगा, हम पुलिस को बुलाएंगे, घर वालों को बुलाएंगे, टो करा लेंगे. You have options. Those options do not occur to this mind that is under stress. That is where CBT and therapy helps. So
Sure.
self-harm के लिए भी similarly there is CBT for specific suicidal ideation. And now self-harm can come from personality component also, not necessarily always depression. It's actually kind of rare in depression, unless there's a lot of aggression and irritability where this is overflowing and you're banging your head or hitting your hands. उसको deal करने के लिए आपको treatment लेना पड़ेगा.
Right. So the medication along with the therapy is an effective way to manage.
Yes. Trying to do it by yourself, I mean, it's a very brave approach, but beyond a point, stop being extra brave.
Right.
It's very brave to ask for help also.
Ma'am, there's one question. What is the alternate to eliminate or reduce anxiety that has embedded physically due to recurrent stress?
I think there are a lot of questions on anxiety. There's another one
Yeah.
on how anxiety-
AMA on depression has turned into AMA on anxiety. So there is
Yeah.
overlap.
How is it related and overlapping? Then you can discuss that a little bit, Dr. Kisle.
Right. So similar chemical pathways. एंजाइटी आप ये मतलब वेन डायग्राम होता था ना बचपन में सीखते थे. एंजाइटी का जो सर्किट और डिप्रेशन का जो सर्किट है, देयर इज अ पोर्शन वेयर दे ओवरलैप. सो द सिम्टम्स ओवरलैप. बट बियॉन्ड दैट पॉइंट वी आर एबल टू क्लियर कट से कि घबराहट से स्टार्ट हुई थी बीमारी या डिप्रेशन की बीमारी थी. नाउ घबराहट में आई थिंक दैट इज एग्जैक्टली व्हाट आई वाज टॉकिंग अबाउट. आपका दिमाग इतने स्ट्रेस में लेता है, आपके ऑप्शंस बंद हो जाते हैं. There is a stressful point to which your mind takes you and then refuses to let you relax or give you better options in life. So but life is not a just two-way street, ये है या वो है. It's not black and white. There are lots of grays. That is what you have to explore. रही बात physically embed हो जाने की, I don't think I understand it clearly. Do you mean physical symptoms like tremors हो रहे हैं, चक्कर आ रही है, choking sensation हो रहा है? So those are panic attacks for which you need medication. Just background anxiety, there are anxious personalities. उसमें coping skills होते हैं, coping skill seminars होते हैं, resilience building exercises होती हैं. Therapy will really help with that. Make a support group or find a therapist who runs these support groups. Do the group therapy. It will really help.
Right. There's another question, like the symptoms which we are mentioning is extremely generic and found with most in everyone. Like how to differentiate the real problem with the transient problem causing, issues because of loss of job or family members losing them or friends.
Okay. हाँ, बहुत कॉमन है. थोड़ी चीजें जेनेरिक हैं, बाकी चीजें जो बहुत स्पेसिफिक हैं, क्लिनिकल हैं, वो आपको डॉक्टर से मिलके ही पता चलेंगी. नाउ इफ इट्स लेस देन 2 weeks, as I said, it's normal emotional upheaval. It's not something you need to really, it will worry you, but you don't need to stress yourself up about it कि अब दवाई की जरूरत है. नहीं, आप उससे कोप कर सकते हो, right? Then there is acute stress reactions or adjustment disorder. कोई मेजर लाइफ चेंज होता है, शादी भी होती है, डेथ होती है, जॉब बदलती है, इट्स अ मेजर लाइफ चेंज. 6 to 8 months everybody takes to cope with it. Although divorce के मामले में हम बोलते हैं 2 साल, right? So give yourself that much time. And if you're still in doubt, and if it's persisting, any emotional state which is persisting beyond 2 to 3 weeks, go to a doctor, right? Diagnosis ultimately तो वही करेंगे ना. अगर आपके पैर में मोच आ गई है, स्वेलिंग जा नहीं रही है, 3-4 हफ्ते से पड़ी हुई है, तो आप जाओगे ना डॉक्टर के पास. Why are you neglecting yourself here? That is my answer to that one.
Right. Seeing a specialist on a regular basis when one is experiencing any kind of symptoms would be the best and recommended solution.
Absolutely. Get the right answer ना. जब तक आपके पास सही जवाब नहीं है, आप आगे का प्लान कैसे बनाओगे?
Right. Ma'am, there's another question. How to conclude if recovery can be done without medication?
I've answered this again and again, and I know everyone is very eager to know whether you can do something without medication. Mild symptoms, आप फंक्शन कर रहे हो, बेसलाइन लेवल पे आपकी उदासी चल रही है, रोना चल रहा है, चेंजेस आ रहे हैं, मन नहीं लग रहा है, यू कैन हैंडल इट विद थेरेपी. Start the yoga, start the exercises, start the socialization, start the group therapy, start the meditation. It will help. And आपको खुद पता चल जाएगा. 1 month of emotional stability, feeling happy is enough to say that yes, now you are back to what your normal is. Now normal for everybody is very very different. Please do not see कि वो बड़े खुश रहते हैं, हम नहीं खुश रहते हैं तो मुझे प्रॉब्लम है. नहीं, अपना बेसलाइन नेचर होता है, अपना बेसलाइन सेटिंग्स होती हैं. What is normal for you, you will know yourself. And the rest, again, go to a doctor, go to your therapist. They know you better. They have seen you over a period of time. So I will be able to tell you कि अब रिकवरी हो गया है, दवाई हटा सकते हैं, थेरेपी में ब्रेक ले सकते हैं, right?
Right. Yes.
So Dr. Kisle, I think it's been a wonderful session, and I miss the questions and the answers you're
Lot of
giving.
questions. हाँ.
Amazing. I wanted to just step in here and ask a few questions, like especially, around the challenges, as a mental health provider and you as a psychiatrist. I think one of the biggest challenge we have is that people are very hesitant to come forward. And there's, like you said, you want to give therapy to every citizen in India, whereas the challenge is it's just the opposite. There's so much stigma associated with it. So, would you like to say something about that, and also talk a little bit about, the initiatives which are there currently in terms of the government support and the helplines, etc. Just to
Right.
most
importantly,
that. Yeah.
Most importantly, ma'am, you know what? I'll start with something personal. I am deeply frustrated. मैं 10 साल से इस फील्ड में हूँ. Never did I think, people kept telling me things are going to change, things are going to change, things are going to change. It's very slow to notice. Hopefully it will change more. आप किसी से मेंटल हेल्थ की बात करो या आप किसी को बोल दो कि प्लीज आप थेरेपी में जाइए, they take it as an insult, right? And that is where we need to start changing. जब आप बदलेंगे then आपके सराउंडिंग में लोग बदलेंगे. They'll be more open to talk to you about it. Now this is correlated to something we've been talking about earlier, where patients are not willing to go for help. You are noticing it, you are telling them, but they are not willing. Put yourself in their shoes. अगर आपसे कोई ऐसा कहता तो आप कैसे रिएक्ट करते? Change that, and then maybe you can help the other person. That I am more accepting that this can be a problem. I will come with you. I do not judge you for this. This is not it's not something bad you're doing. It's not some weakness you're displaying of character. It's an illness. It can be addressed like any other thing, right? And government has taken a lot of interest actually. Again, I'm going to go back to my beloved numbers. Unfortunately, इंडिया में हमारे पिछले 10 साल में सुसाइड का रेट 10% था. It has now increased to 11.7. Now, it might seem like a very small jump, but think of our population, right? Which is why now we have a special suicide prevention program that the government of India has launched last year, where every district hospital is supposed to have a psychiatric center. Every community health center is supposed to have a psychologist. And people are being encouraged to create programs and reach out to them. Reach out to communities, just awareness, like we are doing this. This is psychoeducation. I'm not diagnosing, which is probably why most people feel कि बड़े non-specific symptoms हैं. But this is just to raise awareness that these are the things that can happen. Be watchful, be accepting. That is the first step. And then go for help. Secondly, I would actually like to mention Samvedna's, the MAP, the assessment program you've launched. It's pretty good. It, most people don't like to talk about it. हमारे अंदर अभी भी वो stigma है और एक शर्म है. We are all ashamed and embarrassed about talking about this or disclosing it outside the family. So I have a lot of patients की शादी टूट जाएगी अगर बता देंगे सामने वाले को. लेकिन आप छुपा के भी तो नहीं रख सकते हो ना long term में. So do these online tools. Go check your own baseline health setting. What can you do to improve it? And all of us can use some resilience strategies, some stress coping skills. There are specific workshops for these things and strategies, which I think आपके प्लान में, संवेदना वाले प्लान में भी है. तो आप अपने लिए करो. And it doesn't have to be because you're ill. It's because you're a regular person who wants to be higher functioning or more emotionally stable, right?
Right. Yeah. In fact, I would just like, since you mentioned the MAP tool, so MAP the stool is a really great way for people to do a self check, I would say, and see where they stand, as well as, it also gives you options to create your self-care plan. And then, you mentioned about low-grade depression or low anxiety and things which are treatable at home. So, the tool itself gives you a self-care solution. It gives you a way to track your sleep, mood, and then, these are things which psychiatrists have now told us that, if you can give the patient a printout of that, and I would like to see the patient with that printout, and then, talk to them about what they have done about,
Followed those steps or not.
followed their steps or not. So, which was very interesting. And yeah, and so this is, I think, what we are trying to do through that tool is to break that stigma and let people, have access to at least the initial diagnosis of their situation, and then encourage them to take help, when required. So, I also wanted to just briefly I think this is a very common question we get, is that, should I see a psychiatrist or should I see a psychologist? And since both of you are here, Navya is a clinical psychologist and you are a psychiatrist. So maybe you want to just summarize it for, everybody's benefit, because this is a very common question which we get all the time.
To be very honest, I think you're very lucky that you're getting questions ki psychiatrist or psychologist kisse milna chahiye. I am still explaining the difference between physiotherapist and psychiatrist. So yes, these two fields go hand in hand. It's a team. It is not anti or opposite or different people. At least for me personally as a practice, this is a teamwork. आप clinical psychologist के पास जाओ, आप therapist के पास जाओ या psychiatrist के पास जाओ. So a lot of my patients come via referral from psychologists because they feel we are stuck somewhere and this patient needs medication. अब इतना severe हो गया है कि बात से या फिर वो therapeutic approach नहीं कर रहा है, right? And vice versa. Patient comes to me and I'm like, you are mildly depressed right now. चीजें बदतर हो सकती हैं. आप दवाइयों के लिए तैयार हो, great. नहीं हो, go to therapy. So either or, it's not this is the best or this is the worst. Go to either. Accurate diagnosis is step one. Whoever gives you that and whoever you're comfortable with would be my take on this.
Okay.
Navya?
So, Navya, yeah, do you have
I
anything
totally agree with you, Dr. Kisley. Like, if whatever the client is more comfortable with, it could be a psychologist that they want to approach first. But yes, when we see that the therapist is unable to work on the symptoms because the symptoms do require certain medication, we do refer to the psychiatrist. And when the psychiatrists feel that the therapy is more important along with the medication, they do refer to us. So I totally agree whatever you shared so far, ma'am.
Yeah. So, Dr. Kisley, can you just summarize for us? I think we have had a great session in terms of, the kind of questions we have covered, and I think you have covered a lot of ground. And
Yes.
this, this is such a huge topic. I think we could go on for another hour or so if we
Easily.
want to. But, for the benefit of our audience, and some of them joined a little late, if you could just summarize for us, what is your key, takeaway for the audience in terms of diagnosing, treating, and managing depression, that would be great.
Right. So I'm going to stick to depression since it was AMA depression and not anxiety and everything else. It is too wide in scope, and even depression, like Ashna ji said, we can just continue right now. Takeaway: do not take mild mood fluctuations or regular udasi sadness to be depression. Like we said, it's become very common. वो तो bipolar है, वो तो depressive है. Stop using them as insults, please. You don't say वो तो fractured है या वो diabetic है as an insult. You don't. So let's stop stigmatizing it here. Once we start working on it, it will slowly change society's perception. Symptomatically, अलग-अलग एज में, अलग-अलग जेंडर में अलग-अलग प्रेजेंटेशंस हो सकती हैं, and we need to be aware of them to pick it up. Like heart attack in women and men is different. Depression in men and women is different. Sadness, more in females. Irritability, more in men. Sexual dysfunction, more in men. Can result in anger, can result in avoidance. In women, comes across later. So emotionality will be affected first. बच्चों के साथ चिड़चिड़ापन. Most women come to me when finally the बच्चों के साथ चिड़चिड़ापन comes. उसके पहले आप अपने आप को इग्नोर करते रहते हो. सेल्फ नेग्लेक्ट इन women is more. Suicide attempts and serious suicide attempts in men is more. Right? So these are basic takeaways. 2 हफ्ते से ज्यादा अगर उदासी कंटिन्यूअसली चल रही है along with other changes, चिड़चिड़ापन है, सेक्स में, एपेटाइट में, स्लीप में चेंजेस आ गए, प्लीज 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 कंसल्ट अ डॉक्टर. ओल्ड एज में थोड़ा केयर और चाहिए होता है. ओवरऑल फंक्शनिंग थोड़ा लेस होती है, मेमोरी थोड़ी लेस होती है, बाहर जाना थोड़ा कम होता है. अगर वो और गिर गया है, फोन नहीं उठा रहे हैं, फ्रीक्वेंसी ऑफ टॉकिंग कम हो गई है, उदासी ज्यादा हो गई है, लोनलीनेस का ज्यादा कंप्लेंट आ रहा है, कंसल्ट अ साइकियाट्रिस्ट. यंगर एज ग्रुप काम पे बिल्कुल ठीक है, बिल्कुल परफेक्ट परफॉर्म करते हैं, घर पे अवॉइडेंस स्टार्ट हो गया है, चिड़चिड़ापन आ गया है, बर्तन फेंक रहे हैं, ड्रिंकिंग हैज स्टार्टेड, सब्सटेंस अब्यूज इज मोर कॉमन इन यंगर पीपल विद डिप्रेशन. उनको आप एडिक्ट मत लेबल करिए. Treat the depression, you will automatically see the substances being controlled, right? Forgot to mention it earlier. So these are differences. Be aware of those. Please let's get over this thing कि बिना दवाइयों के ठीक कर लेंगे, बिना दवाइयों के ठीक कर लेंगे. आप, mild anxiety. My voice was shaking in some parts of this interview. If someone's been here for the whole hour, everybody gets anxious, everybody gets sad, but we have ways to deal with it. And everything is not a diagnostic illness. And illness is not a label or a stigma. कोई भी कभी भी बीमार पड़ सकता है बिना चेतावनी, बिना वार्निंग के. We have just been through a huge pandemic without any warning, right? So takeaway would be, don't neglect it. Do not try to keep doing something yourself which you know you don't have the skills for. हमारी literally training वही है, ठीक है? So up to a level, if you can do it yourself, great. But beyond that, the minute you think you need help, please ask for it. It's very brave. I think it's very brave in today's day and age to go for help. थेरेपिस्ट फाइंड करिए, डॉक्टर फाइंड करिए, जीपी के साथ जाके बात करिए, बट कहीं तो जाके बात करिए.
Wonderful, wonderful. Dr. Kisle, it was lovely listening into you, and I think the audience would also agree with that. And I think it's been.
I hope so.
for
I hope
me,
it's been educational more than anything else.
Yes, absolutely. Eye opener. Some of the questions are very relevant. And for everybody's information, Dr. Kisle is available for consultation through Samvedna. And we also provide psychotherapy and counseling services for different issues, not only depression. And we do follow a very clinical approach. And like Dr. Kisle said, we work with the psychiatrist, and or you can go to a psychiatrist first, or you can come to a counselor first. So I would like to just thank everybody for joining in today, and again wishing everyone a very happy new year. The Hindu calendar, Makar Sankranti is today, yesterday was Lohri. And we hope that we will all spread light into our hearts and be more open to seeking help and treatment as required. And do take a self-assessment if you haven't taken that yet at map.samvednacare.com. And visit our website. And if you have any questions, please write into us. I saw some suggestions. People have asked us to start a helpline. I just want to share with you that Dr. Kisle was mentioning this as well. We do plan to start a mental health support group specifically for mental health issues, where we would like to do like a group therapy kind of a session. So, we would request you all, those who are interested, to sign up for that. And, over a period of time in the next month or so, we do plan to start that mental health support group in a very focused manner. And so, please do look up our website. Can somebody just share the website details? Thank you, Dr. Kisle, once again. And
Most welcome. Thank you for having me.
With you. And thanks a lot. Yeah. Thank you,
Glad
Navya.
we started the year on this note.
Yes. Thank you, Navya. Thanks a lot.
Thank you.
Thank you, everyone. Thank you for joining. Thank you. Bye-bye. Thanks.